Yeah, yeah, yeah. Okay.
Hi everyone, welcome to our next webinar, the GAA London, Gujarati Area Association London webinar. We were away and absent last week, and so many of you missed us. We were inundated with calls and messages to say when can we resume. So we've resumed. Um, Thank you very much for joining. Thank you for your patience. We've got a fantastic topic scheduled today, and we've kindly got Uttam Chauhan, who's a pharmacist from North Wales Hospital. So he's dialing in from far afield. I'm sure the weather's different in Wales, isn't it, Uttam?
Yes,
Definitely different. It's raining all day. It's been raining all day today.
It's been raining all day in London as well.
No,
It's been
no,
raining in London.
no
So
sun. No sun at all, unfortunately.
Oh God. Well, hopefully we'll get some soon. So
Yeah.
thank you very much for joining us today, Uttam. And for those that don't know Uttam, he took a couple of sessions for us last year in July, and very interesting topic. So I'm going to let him explain his background a little bit, but I'll give you a little snippet. He's a pharmacist. He's at the front end of pharmacy, working at the hospital in North Wales. And I think his insights are very, very valuable for us as a community. So last year he talked about a number of things, and it related to medication on typical conditions that we get as a ethnic community. So one was medication for blood pressure. Two, we talked about medication for type 2 diabetes. And three, we talked about medication for chest pain and heart conditions. All very, very important. And I was asking them, to perhaps talk a little bit about, what's been going on since July. And I headed up the session as medication and you. I want this to be an open session today, because I think lots of things have happened, and I'm going to set the scene a little bit. Um, and I sort of want to make this an open Q&A session, and leave it to us to talk a little bit about our own specific issues that we've come across. And I'm going to, again, I said I'll set the scene, so I'll give you a chance. I want people to talk about medication and yourselves, because we all get certain medications, whether it's blood pressure, whether it's diabetes, whether it's for heart issues, but we're all different. And therefore, I want people to talk about conditions that they have and the medications that they are prescribed. And also asking someone like Uttam, why am I prescribed these? And that's a healthy question to have. Um, I also want us to question why certain medicines are prescribed to us, because I feel that people are prescribed medication and they don't question why they're prescribed, because they go into, a very professional person with a white coat, a GP, etc. They give a medication and they pretty much say that person knows what they're talking about, and they then, take the medication and continue on with their life. And the third thing we will touch upon is side effects, and how to report them. So again, what I want people to talk about is medication that you're currently undertaking. Let's question why you've been given those medications, and let's question some certain side effects. So I want to just sort of us to cover those topics, but in your own experience. Okay. Um, So, Uttam, before we sort of open the floor up to people and their questions, I want them to digest that. And I want people to ask questions either by raising their hands, not a problem, or putting them in the chat. And we will filter them as they go along. So please be open. Please be as candid as you can. You don't have to mention names if you don't want to, but can mention certain circumstances. And I welcome people to open up in this session. So with that, I'm going to give you a little bit of housekeeping. Um, One, this session is recorded. It's being live streamed. So people that have missed this session will be able to get a replay of it. You too can get a replay of it. If you have an issue with things being live streamed or being recorded, what I would suggest is you drop out from the call. I would like you not to. This information doesn't go anywhere other than GAA's YouTube channel, and it's available for public benefit, i.e., for education. That's what these sessions are intended for. And GAA is not promoting any medication, giving any advice, and neither is Uttam. We're just having a general discussion to raise awareness. So they're the two housekeeping rules. With that, Uttam, I'm going to hand over to you to give a bit of an introduction, to remind people who you are and your background, please.
Okay, my name is Uttam Chauhan. I work in North Wales and I've been here for a number of years now. And my main experience is in hospital pharmacy. And what we discussed today, I don't want to betray any confidence that you have with your GP, with your professional staff who look after you. We're just going to talk in general terms, and if you're happy with that, that's fine. And so we'll keep it in very general discussion, and we won't go into any specific kind of issues that you may have. We can only talk about in very general terms, and leave it at that point as a way of introduction. And also, the other thing I would probably say is that over the last probably 15, 20 years, my experience has gradually been very, very refined actually. Although I'm a pharmacist, but I specialize in very narrow area, you see. And that's how many hospital pharmacists now work actually. You will see even in many hospitals, you'll see people people working in a specialty of heart disease, specialty of gut problems. Some very specialist pharmacists will be dealing with liver problems, with uh, kidney disease. So all sorts of different kind of specific things are happening over the last few years, you see. And even if you go and see in your GP surgeries, you will probably encounter pharmacists or pharmacist staff now there working in those kind of places as well. And they are to support the doctors and the nursing staff to make sure that we get the best out of the medicines that we use in this country. Okay, I'll stop there.
Thanks, Uttam. Thanks for that. And look, everyone, please, this is a safe space. Please use this forum to share your experiences. Again, as Uttam has said, we're not trying to breach any confidentiality. We're not trying to override what doctors are saying. They know you better than anybody, but this is just so you might want to ask questions. So I'm going to get the ball rolling, and I've had a couple of experiences, with family members very, very recently, and I'd like to share those with you, just so we can sort of get Uttam's experience, but also other people's experience because they may have encountered something similar. So, my wife was taking certain medication for a condition that she had, and as a result, her blood pressure had lowered. Okay, and the doctor took her off her BP medication. Um, my wife accepted that, and recently her blood pressure has started to increase. Now, what's been happening as we get older, we get certain conditions and certain medicines are prescribed. But what we don't know is how two or three medications for two or three conditions talk to each other. And doctors are regularly trying to assess, whether they should be increasing certain medication, in this case, blood pressure, or reducing it and to regulate. And that's one thing that's happened. And I think we're not good at following up. Sometimes, why did my wife find out? Because she was getting headaches. And then she went to have that discussed with the doctor, and doctor, actually, we need to revisit your medication. So that's one issue that I wanted to share with people, because I think people have gone through similar issues, but maybe are not okay to open and put their hands up to say that. And another instance that's happened, again, to a family member who changed GPs actually, and was given medication and prescribed certain medication maybe 5 or 6 years ago, and only recently realized that they were taking medication that they no longer needed to take medication. So, many years ago, complained of tightness of the chest, was given an angina medication. Nothing, things, conditions improved, the person's health improved, but actually they were still taking that medication because they just felt that's something doctors prescribed, and they continued on with that. So, Uttam, I don't know if you've got any feedback on those, or is this something quite general that you come across with people? Is this
Well,
very normal?
it is a common occurrence actually during the main issue with certain groups of medicine, and one of the biggest problems, one of the biggest diseases in the world is high blood pressure, and quite a few people take tablets for high blood pressure, and and so and majority of them will probably be taking two or three medications for blood pressure to control the blood pressure well. So if they're taking either two or three medication, and we have had some very good hot summers, and if people don't look after themselves, and if they become dehydrated, and you're taking all those tablets when you're dehydrated, then you can run into problems, you see. And I think if you listen to the news, they do warn you that be careful during the hot weathers, and if you're taking all this kind of medication, and the weather is pretty hot, you have to be careful about your medication and have a chart to find out as to what you can do, and you have to keep yourself well hydrated. And if you're not well hydrated, then the risk of problems do occur, unfortunately. So that is one thing. The other thing that people can do is to look after themselves as well in terms of their blood pressure. Just don't rely on one single reading that the GP has given you, because you don't see your GP. Probably you'll see your GP once or twice in a year, and they will only take your blood pressure at that particular point. But you can do something for yourself at home, and you can monitor your own blood pressures, and you can keep a record on your telephones, because telephones, these today's telephones, they keep all sorts of records, and you can see what's happening to your blood pressure trend. Actually, it's not one single reading that you need to look. You can see what over a period of time what's been happening, and if the blood pressure is falling, you can take that particular record to your GP and saying, this is what's happening, these are the tablets I'm taking, what do I need to do, am I getting symptoms? And the kind of symptoms, if the blood pressure is falling, you do become dizzy. Dizziness, as we get older, unfortunately becomes more common, and with blood pressure tablets, and if you do fall, you can fall actually, and as we get older, and the problems of falls comes with a much bigger problem. So those are the kind of things that you have to look out for as well, you see.
Yeah, that's great. And actually, that's very relevant because, one of my family members, they suffered from low blood pressure, and they had the postural testing done. We found out that it was basically from lying down to standing up, the blood pressure would drop. And why did we investigate that was because the person felt dizzy and, had sort of momentary lapses. And that's why we
Orang itu register karena mana pharmacist tiga cara pakai itu guruan atau biasanya register cara.
Sorry, I didn't get that.
No, don't worry. Can I just ask people if they're not speaking to keep themselves on mute? Um, but thank you for that. So I think that's relevant about low blood pressure. But I wanted to ask you two things. On blood pressure, you said it's good advice to regularly test. Do people, should they have these kits that they, blood pressure measuring
If,
kits? Is that advisable?
yeah, well, I think if you speak to your GP colleagues, they will probably tell you it is advisable, and before they start the medication, they will probably ask you to test the blood pressure at home for 7 days to see what your blood pressure trend is, you see,
Yeah.
and before they start the medication. And it is more and more common to have those kind of blood pressure monitoring devices at home
Yeah.
and to keep records of it. The more important thing is to keep records of it, yeah, to see the trend, what is happening, and if you even if you keep a record on your diary or on a piece of paper with a date, what the blood pressure readings are and what your heart rate is, and then the doctors can see that what's been happening. Yeah, they can see the trend, what's been happening. Is it stable or is it going down or is it going up? What's happening? So it is very important.
Interesting. And the other bit that I took away was this thing about dehydration. You mentioned that people are taking sometimes two or three medications for blood pressure. The most probably they're taking medication for other conditions as well.
Yeah.
Um, and dehydration, is it because you're taking lots of medication that you should keep hydrated? Is that what
No,
you're saying?
no, if the more important thing is to drink adequate water, irrespective whether you're taking tablets or not.
Yes.
And my advice, my general advice is that if as long as you drink sufficient to keep your mouth moist, it shouldn't become too dry.
Hmm.
So if it becomes too dry, then you're already dehydrated, you see. So
Mm.
you have to keep your mouth moist, you see. But you have to be sensible as well, you see, not to overdo it, because drinking too much water can cause problems as well, you see, as drinking too little water as well, you see.
Mm.
Yeah. So as long as your mouth is moist, sufficiently moist, that's fine.
Brilliant. So we have a question, and I'm going to ask it in a minute. But again, I'm going to encourage people on this call. Let's use this opportunity to share information, share experiences. So please raise your hand. Please put your questions into the chat. So Harish Kari has come out with a question. I want to know if you can talk a little bit about metformin.
Yeah.
So Harish, do you want to ask the question?
Yes, please. Yes. I won't take too much time. I'll try and explain in short. I have been diabetic for past 25 years. I was on metformin 850. Then I was managing it properly, so my doctor make it to have it 500. Now, the new research says that metformin was good for heart and controlling the sugar. But now the new research says that it is affecting kidney. And I have found out now from my blood test and all that, that it has affected my kidney. So my doctor has stopped me taking metformin and he has increased my glycoside.
Yeah, interesting question. Yeah, as you mentioned, you have got type 2 diabetes. Yeah, and you have got a long-standing 25-year history of diabetes. And one of the problems with type 2 diabetes is that it's not related to metformin, but is related to your diabetes. And with diabetes, as I mentioned in my talk in June, the complications with type 2 diabetes is that with time, the kidneys slowly decline. They continue to slowly decline, you see. And when they come to a certain at a certain declining rate or time, they have to stop the metformin, because the metformin becomes more risky when the EGFR is less than 30, you see. So in type 2 diabetes, that is one of the issues. It is not the drug, it is the condition that is the problem, is the problem.
What happens now is, sorry to interrupt. What happens now is, I know we are on a public platform now, but I got to mention this. I cannot aim properly now. I have to sit down, if you see what I mean.
Yeah, yeah. The long-term complications of diabetes are many, and it does affect many things in the body, you see, and it can affect your as I mentioned, it can affect your eyes. It can if you can have peripheral neuropathy as well, and some people have problems with standing up, and the blood pressure and all sorts of things can happen. So in type 2 diabetes now, the management, metformin is a very, very important drug, and it does save lives, you see. But after metformin, the 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 main thing now is to use, if I may put the cards on the table, because with type 2 diabetes, what what kills people with type 2 diabetes is heart diseases. Yeah, and we need to prevent those heart diseases. And that's why, and all the drugs like the glycoside and the linagliptins, they don't prevent heart diseases, unfortunately. Yeah, so we need to find drugs that prevent you dying from heart diseases. And there are some new groups of drugs that have been out now for probably 10 years now. And and that's the type of groups of drugs that we should be using to in type 2 diabetes after metformin, to see whether we can help with heart diseases along. And the other advantages of these new groups of drugs is that it also prevents the kidneys from failing. If you live in a bigger inner city place, so in your uh, renal units in your hospitals, quite a few people will be of Indian origin saving dialysis now. Not the white people, but the Asian peoples, because type 2 diabetes is quite common in Asians, you see. So we need to prevent that happening, and we should be using the newer types of drugs to prevent that happening, you see. And there
My,
is
my
there is so
doctor,
much information about that.
my doctor says I'm not drinking enough water. So I devise a system whereby every time I walk into the kitchen, whether I'm thirsty or not, I fill up a glass and drink the water. But
As long as your mouth is dry, moist, that
yeah,
is fine, you see. But there are the other important bit in in kidney disease is that they need to monitor your how much protein you're losing in your urine, and that's what they need to check, you see. And unfortunately, that does not happen that frequently as it should happen. And if that did happen, and then they can take corrective actions to do that.
is it possible to use those strips? The urine strips. Would
No,
it help?
no.
No.
They need to have proper protein measurements in your urine, and they can analyze it. And then from there on, there's some guidance as to what should be happening to you.
I used to have my blood test every 6 months, but my doctor said, no, that's not enough. So I have it every 3 months now, which
Yeah.
is quite good, really.
Well, they're testing for your HbA1c actually.
Yeah, yeah.
Yeah.
Thank you for
Thank you very much.
that
But it's
explanation.
important to look after your diet as well.
No,
Yeah.
I'm managing it. My diet is very good.
Okay, fine.
Because when you think about it, 25 years now, and I'm managing it very well.
Good. Excellent.
Thank
Keep
you.
doing
Thank you
it.
for explanation.
No problem. You're welcome.
Thank you, Harish Bhai. And look, thank you for opening up, because you know, mentioned very sensitive information, very personal information, and I appreciate that you consider this as a good space to do that. So thank you for doing that. I think lots of issues were raised there, and if people have similar issues, please, let's use this time. Again, I keep saying to share and educate each other. I think it's important because these conditions are prevalent in certain ethnicities, especially those people from Southeast Asia. Talking about diabetes, I know I'm sort of moving on a little bit, but I just want to say that GAA London is working very closely with Brent Health Matters. We're going to be running a 4 to 6 week program on diabetes, which is going to be nutrition, exercise, and education. It's going to be at Kenton Hall. So watch out for this information. We're trying to capture people that are pre-diabetic to educate them so they don't get that far. But again, even if you're diabetic and you're type 2 and you suffer from type 2 diabetes, you're welcome to attend these sessions. We held them 2 years ago. We had a bit of a gap last year, but we want to make this more regular. I'd like to run it twice this year because the classes tend to be quite small, 10 to 15 people. So we want to get as many people coming through those clinics as much as we can. That's a bit of a plug on what we're going to be doing in Kenton Hall in person, not the webinar, but something to keep an eye open for. So another question was asked, and it's by a lady called Sangeeta Arya. She talked about alternative supplements versus medication given by GPs. And I don't know, Uttam, if you can talk about that, but Sangeeta, are you able to say why you raised that question? Have you come across this and had been advised, in that direction?
I can. Yeah, I've been diagnosed pre-diabetic and pre-cholesterol, and I really don't want to go down the medication route. My mum's gone through hell with medication, and then her organs have been failing. She's got everything: diabetes, cholesterol, the lot, and the amount of pills she's taking is affecting all her other organs. And I know it's going to be in the history of our family. So I really don't want to go down that route. And I am looking at alternatives. So I'm not sure if that's going to help or not, but anything to avoid medication.
Yeah.
Obviously, diet is important. And I am doing my diet. I'm doing my exercise. But anything extra, just to help me not getting onto those medications would be really good. And
In terms of complementary medicine, that is not my field, to be honest, and I don't practice it myself, and I don't go down that line at all. There are certain drugs that can be a problems with if you're already on some medication, if you're taking some additional complementary medicine, then you need to ask the pharmacist whether those drugs, the drugs that you're taking, will interfere with the complementary medicines that you want to take. So that's very important that you check that they don't interfere with each other. So that's very important. The only other thing that I would subsequently add at this time of the year in winter is very important that we do take our vitamin D tablets. And that's so important as we had a talk on vitamin D supplementation before Christmas from from Preston. And we Asians don't have sufficient vitamin D intake. So it's very important to take that, you see. Yeah. So I will leave that on complementary medicine.
Great.
Great, thank you.
And Sangeeta, just from your experience, so you mentioned, you're pre-diabetic, you are sort of bordering on, cholesterol levels, which might be high. Is it that you don't want to go on cholesterol medication? Because I'm in the same boat. I've been prescribed to go on to, cholesterol tablets and statins, and I'm staying away from it. Is that what's driving the alternative?
Yeah. I don't want to go on to any medication, so anything I can help.
Yeah.
And yeah, I'm on a pre-diabetic course, the one you were just organised talking about, but through obviously my area and through the GP. But it's no matter how much we do, it's in our genes. As the doctor said, we're Asians and we're going to get it.
Yeah, this is the problem in Asians, and unfortunately, once your cholesterol level is on the high side due to genetics, dietary modifications is not going to bring your cholesterol level down to the extent that you need to get down, you see. And that's why people end up on statins. Statins saves lives, and it does save lives, and there is quite a lot of proof to demonstrate that, and is so important that you find a statin that suits you, you see. And there are several alternative statins available that the GPs can prescribe that can suit you to bring your cholesterol level down, you see. The most important thing is to bring your cholesterol level down. Dietary modifications, complementary medicines, in my general reading, does not reduce the cholesterol level to the amount that you need reduction, you see. So that's the issue that we have, and that's why people end up on cholesterol lowering tablets.
Then do the statins like metformin, goes to
Metformin is not a statin.
No, I know, but if so does metformin ruins your kidneys? So
it does not ruin your kidneys. Full stop. It does not ruin your kidneys. Yeah, we use metformin by the gallons in every type 2 diabetic patients. There are millions of diabetic patients. It is the disease state that is the problem. It is the disease itself that is causing the problem. It's not the drugs. Yeah, it's not the drug that is causing the problem. It is the disease itself. So the main thing is to prevent the disease happening in the first place. And if you can control the diabetic disease well, that means that you're keeping your HbA1c under tight control, which is very difficult to do. But if you can keep that under tight control, then it prevents all these complications happening, you see.
Yeah. May I just ask a question about that, please? Because I always have a problem with William taking statins, because I do know that it's supposed to help control your cholesterol. But his cholesterol is always on the 2-3 mark. And I'm saying you don't need to take statins because your cholesterol is never high.
So cholesterol, the other reason why we give people cholesterol is that once they have had a heart attack, for example, if they have had a stroke, or if they've got a peripheral vascular disease, then cholesterol tablet is automatically given to them, is to prevent them having further problems, further heart attack or further strokes and things like that, you see, is to prevent that, more of that happening at a future date. So once you have had a, say for example, once you have had a heart attack, it does not matter whatever your cholesterol is. We need to give you statin to prevent you getting another problem.
That's it.
Yeah.
Okay.
Thank you for
I'm
that.
asking about my thing now.
No, when we
Yeah.
get to generals.
No. A quick question.
Yeah, William.
And I have
Sorry, I just put him on.
You put on mute.
Carry on, sorry.
I have been a diabetic for about, well, I'm 80 now, 56, nearly 60 years. And not very long ago, my doctor sent me to one of these outposts in Brent. And the person there took me off of insulin and put me on a thing called Trulicity. Now, with the Trulicity, I have lost so much weight. My blood sugar readings are normally between 4 and 7, which is to me is normal. But I am losing a lot of weight, a tremendous amount of weight. What should I do? I'm not getting any particular advice from the doctor. You either have the diabetes or you either have that, one or the other.
Well, Trulicity is another group of drugs that have been used in people that you probably have heard in the news with obese people, and like the Manjora and Viogitab injections. You see, it's a similar kind of medication, and they lose weight, and because of your BMI or because of your body size, they might have started that, you see, to lose weight, you see. That is one of the reasons they might have used it. But if you don't, if you need to go back to them and ask them, could you give me a good explanation as to why you have changed one to the other, and what are the benefits of changing to the newer one, and what do I expect, you see. So you need to ask them the questions along that line, you see, so you're more prepared and you're more informed, actually. So just don't come away with taking that prescription and saying, okay, I'm going to inject this drug, but you need to ask them the questions as to why am I on it, what are the benefits, and what is it going to do to me. So you need to ask those kind of questions so that you become familiar as to what to expect with the medication, you see. Yeah. And I think that is what we don't ask, you see. Sometimes we just take that particular prescription and we just walk away. And we should be strong enough to say, why are you changing this from this particular thing to that particular thing? And what are the benefits, you see? You need to ask them those questions.
I have had checks at Norfolk Park Hospital for the same thing, but I got nothing concrete.
Yeah, they just told you to carry on.
You just said to
Something that
carry on.
Yeah. If so, okay. So have you lost weight from it?
A tremendous amount of weight.
Well, that is one of the benefits of this new, because just looking at you by sitting there, I think you are a tall chap.
Yes.
You're just looking at you, and I think you are of good size, actually.
No,
You're,
I've lost too much.
well, that's why you need to lose. You have to lose weight, you see, and by losing weight, you will control your diabetes as well, you see.
I can control the diabetes now.
Well,
When I do the blood sugar reading,
yeah,
maybe
but
once every 4 or 5 months, it's 4.4 or 5 point something,
yeah,
but it's
but the
never
most
high.
important thing is that you don't become too low. That's the
Going the other
important thing.
way.
Yeah, you don't want the too low is more harmful as well, you see. So if the blood glucose falls to below 4, that becomes more dangerous. So that again is very important to be aware of as well, you see.
So if I stop taking
Well,
the
it's something,
Trulicity,
no, it's something that you need to discuss with the people who look after you. Yeah.
Thank you.
thank you.
Thank you.
Thank you.
Any more questions?
Yes, please. Hello.
Hello.
I in January, I had all the testing done for the pre-operation. I had a fall, and my elbow. They were going to operate me on my elbow. So they did, and then they did. It came out. I'm on a type 2 diabetic. So the reading came as 73, 74. So they said they can't operate me because my HB1C is quite high. And so then I was being put towards GP. So I am taking 2 metformin 500 in the morning and in the evening, and also dapagliflozin.
Yeah,
And thereafter, my GP has put me on glucoside to reduce the sugar, and I'm monitoring every day. It comes to about 4.1, 4.3 after meals. So is it bad? Shall I discontinue the glucoside? I think I'll talk to my GP about this.
So are you getting any symptoms?
I'm not getting any
You're not
symptoms of
of
lethargy.
hypoglycemia.
No, but after this, I'll stop taking glucoside at the moment. For 2 days now, I'm not taking it, and still the reading shows not by not taking it, still the reading is still the same 4.1, 4.3.
So the important bit is that you're taking the metformin and the dapagliflozin.
Yes.
Yeah, so continue with those two, and as long as your readings are fine,
Yes.
and if the readings continue to be between under 8, between 4 and 8, or under 10,
Yes.
and then you need to get your HbA1c tested,
Yes.
and hopefully that will be from 73. It should drop down, you see,
Yes.
and once it drops down, and then they should be able to do your operation, you see.
Yeah, so it was around, you see what happened in December. I had a very bad flu, and I had a problem with breathing. I had an asthma attack. I don't take inhalers normally, but I had, because it was such a bad flu, and had taken this. I was taking prednisolone. It was a steroid
Prednisone.
tablets.
Yeah.
8 tablets I was taking in one go, and it was about 4 to 5 days. Now in December, I had taken about 4 to 5 days that one. Do you think it is because of the steroids and I had a bad flu? That's why my HB1C went up in
Well,
January.
when you're taking such high doses of steroids, 40 milligrams a day for an attack of asthma, which can so normally they tend to give it for about 5 to 7 days,
Correct, yes.
and that can increase your blood glucose quite dramatically. So it can become out of control, you see.
I did tell them at the hospital, now please do another test, HB1C, and carry on with my operation, which I've been waiting for so long. But they say, no, we can't do it at the moment. I said,
So
because
that
of
it normally they tend to do it after about every 3 to 4 months, something like that, you see.
correct. So I have to wait until April now.
Yeah. So because and once the HbA1c gives you a glucose control over the previous 3 to 4 months, you see.
Yes,
You have to
yes.
let it along that it takes that length of time for it to get a proper meaningful answer, you see.
Okay, fine. Okay,
So
thank you.
as long as the dapagliflozin and the metformin are suiting you, they are not upsetting you in any way, I would continue with them.
Yeah, they're not upsetting me. I've been taking that. It is fine with me at the moment. Yes.
And if I may ask about your inhalers, And which inhalers are you using, if I may ask, please?
On the brown inhaler at the moment, but my breathing is okay, so I'll stop using the brown. I was taking it in January. If 1 week I took 1 or 2 weeks. Now I've stopped it after that.
How many asthma attacks have you had?
Only once, first time, because it was first time in December. It was due to the very bad flu and my breathing problem at that time,
So
first
did
time.
they diagnose asthma? Then did they make a proper diagnosis of asthma?
Asthma? No, they didn't, not really.
Fine, I'll leave it at that. Then they have to make a proper diagnosis of asthma because these kind of things are so important actually, is to get a proper diagnosis.
So I've spoken to my doctor about this, and I think I'll be seeing the doctor to check up on this asthma thing. So let's see. Yeah, if I have got diagnosis, and then if I have to take the inhaler, then I can take it.
Yeah, once the diagnosis for asthma has been made, and once you've been given that diagnosis, there are proper diagnostic criteria. They can't just say that because you've got a wheeze, you've got asthma. You see, there has to be proper diagnostic. Just like you go for radiology to see this is a broken bone, so they can give you, and similar kind of tests are available for asthma. You see, and
Mm-hmm.
and the reason why I ask you about your inhalers is that the brown inhaler that you're using, it takes a long time to work. So
Okay.
if people who are listening to this particular talk, if they are truly asthmatic and they are using the brown inhaler as and when they need it, well, that is totally wrong. You have to use the brown inhaler on a regular basis to prevent you getting the attacks of asthma, you see. That's the whole point of giving you the brown inhaler, is to reduce the inflammation in the lungs. And you have to use it on a daily basis, not as and when you feel like it, but on a daily basis, you see, to prevent it. Uh, Unless your asthma is so infrequent, then you can use it on a combination inhaler of asthma with a beta 2 agonist, you see. But if you're just using the brown inhaler on its own with a steroid inhaler, it takes a long time to work. So you have to use it on a regular basis every day. And the other important bit with inhalers is that you have to use a device, a device. So the more of the drugs get at the bottom of your lungs, you see. Because what people do is put the inhaler in your mouth and they just do that, and it doesn't get into your lungs properly, you see. There is a proper way of using the inhalers as well, you see.
Okay.
Thank you, Gita, for sharing as
Thank you.
well. And I'm going to go into a question that was raised by Narendra Rupara earlier. But before I do that, I was going to ask just a general question of them. It's about medication and when is the right time to take medication. Is there, some medications you're encouraged to take it after meals? Is mornings the right time? Is evenings the right time? Do you have any guidance you can share with us?
Well, the most important thing, if the medication has to suit with your lifestyle. Yeah. So if you're taking a medication which is once a day, if it suits with your lifestyle that you want to take your medicines with your breakfast time, so be it. If there is a very specific need to take your medicine on an empty stomach, then you have to follow those guidelines, you see. Um, um, for example, if you're going to take if I'm sure many people will be taking their iron tablets, because one of the other problems with the Asians is that we are all iron deficient, you see. So we are prescribed iron tablets. Now, the correct way of taking your iron tablets is on an empty stomach, nothing, no food or nothing at all. Yeah, just completely on an empty stomach. That means no food an hour before and no food probably an hour after those as well, you see. Completely on an empty stomach. So it's very important to do it that way, you see. Other tablets like penicillin tablets, if you take it with food, the amount of the penicillin that gets into your blood will be reduced if you do take it with food, you see. So you don't get the benefit of it. So there are certain tablets you have to follow the instructions, but most of them you can get away with it, you see.
Interesting. Okay, so let's pass on to Narendra. Narendra, are you able to? Can I invite you in to ask your questions? You got two, I think, here. Okay, well maybe I can ask them. So Narendra was prescribed with cholesterol tablets, but you know was prescribed as reassurance. Didn't have any conditions, but was basically told that this is to prevent the condition from happening because they're an ethnic minority. So any thoughts on that? Statins being prescribed because there's sort of conditions historically in our genetics when they don't have high
They,
cholesterol.
they normally do something called Q risk factor. They look at the Q risk, looking at your age, your previous history of blood pressure, your waist circumstances, your smoking history, and all that, and your cholesterol levels and all that, and they can work out what the risk of dying from cardiovascular disease is in the next 10 years, you see. And if your risk is on the higher side, then they give you cholesterol tablets, you see. It depends on your Q risk score actually, or some kind of a scoring system, and that's how they should do it actually.
Okay. With statins, because I've got this issue and I'm in denial. I haven't taken them, and once you're on them, my fear is that you can't come off them, and the GP will. It's easier for them to just give them to you and say, okay, just continue on with them. Can you come off statins?
Well, if you can come off statins, but the whole point of giving you statins is a preventative medication, is to prevent you getting the problems at a later date, or to reduce your risk of getting strokes, heart attacks at a later date, you see. That's the important bit, is to prevent it happening in the first place. So if you're going to take it just for a few days, forget it, there's no point. You have to take it on a daily basis. The whole point of preventative medication is to prevent getting the condition, because it's, for example, if you get a stroke, the implication of a stroke are quite horrendous actually. It affects not only yourself, it affects whether you go back to work, it affects your whole life, your family, and everything, you see. So strokes are very important, and they're quite important implications for you and for the society as well, you see. So it's to prevent those kind of things happening in the first place. That's why cardiovascular diseases are very prevalent in this country, and most of them are preventable. 70% of the cardiovascular disease, which is high blood pressure, are preventable, you see. So we need to do everything to prevent those diseases happening in the first place, and we have to look after ourselves. And taking cholesterol tablets helps us to do that, you see, if your risk factors are in that group, you see.
Perfect, thank you.
That's great, thank you.
Did you want to ask your second question on vitamin D?
Yeah. I was feeling very, very lethargic, you see, and eventually they managed to request the blood test, and it came out to be very, very low in vitamin D. So I think they prescribed, I can't remember now whether it was 20,000 twice a week or once a week, but irrespective, it was on for 3 months. And then after that, it was supposed to be over the counter. So with regards to over the counter one, how much should I be having on a daily basis now? What strength? And the other thing is, I think I've been reading, I think was it on the main news that if you have too much vitamin D, like intake of tablets, it's not very good for you as well. Because some people might be thinking, if they have 20,000, right, they don't have to have it over so regularly or whatever. But then, are there any risk factors to it to take high dosages?
Yeah, I would refer you back to the talk that one of the retired physicians gave from Preston on vitamin D, and that's a recorded program on this particular topic. It was a very good presentation. I think Dr. Grimes or Dr. Greaves, I think his name was. And vitamin D deficiency is so prevalent. Probably the whole of the United Kingdom is probably vitamin D deficient, you see. And we, especially in the winter months, we have to take our vitamin D, and probably about taking 10,000 units or 1,000 units or 2,000 units per day is probably sufficient on a daily basis.
Okay. That's great. Thank you.
But I would refer you back to that recorded program that we had on vitamin D. That was very good.
Okay. If you can, I mean, if somebody can direct me to whichever it was, that'll be great.
Yeah,
Okay.
definitely. So look, for people, if you're not part of our YouTube channel, on our WhatsApp, our community WhatsApp, please ask to register for it, and it'll give you access to our YouTube channel with all the discussions. Or reach out to me or Bana at GA, and we'll add you to those groups, so you can avail of all the playbacks.
Sorry, can I just add on something?
Yes.
With the vitamin D, right, at one time they used to do regular kind of checks, like blood tests and whatever. And again, I think it's one of those things that the ethnic minority with dark skin and whatever have lack a lot of vitamin D. But now I think they're not doing the tests anymore regularly, or unless if there's a need for it. So,
I'll tell
that's
you,
another thing we need to be careful on. That if you feel like, for example, I had to go there about 2 or 3 times before they decided to do a blood test with and check vitamin D.
that is true that they don't routinely do vitamin B levels. Just tell you a story. Following that particular presentation from on that last year from Dr. Graves from Preston, I was speaking to my retired boss. Actually, we went out for a meal, and I told him about uh, um, this particular charts that we have on Thursday, and I told him about that vitamin D meeting, a 1 hour meeting, and he subsequently went to his own GPs, to the local chemist, where they measure the vitamin D levels, and his levels came back so low, and he went on replacement therapy, you see. So vitamin D deficiency is very common, unfortunately.
I think we have to get.
And also, I tried to find out whether you can have injections, but apparently not for vitamin D. I think you can for B12, but not for vitamin D.
Not for vitamin D. Well, there are injections available, but that will probably be on a very, very specialist basis. But on the whole, the tablets are the best way to go.
Thank you very much indeed for that.
Okay.
So Narendra and everybody will get you hooked up to our various YouTube channels and chat. So please ask for that if you don't, if you're not, if you have trouble. We must get Dr. Grimes back again, I think, Uttam, because I think that was a good talk, but we covered a lot of ground. A lot of it was history on cardiovascular disease, but I wanted to talk about vitamin D, so we'll invite him back as well. So I think it's quite important. We've had a couple of questions asked, which are extra. One was and this is Mustiq Jaffa. I don't know, Mustiq, can I invite you in to ask the question? Would you like me to present it to Uttam on your behalf? Well, let me present it to you, Uttam, and then if Mustiq comes in, that'd be great. So talking about have calcification of vascular vein around my hips, calcification of the vascular vein around my hips. And I've been prescribed aspirin. Is this the correct diagnosis?
Well, I can't comment on the diagnosis. Yeah. So what calcification means is that there is a narrowing of your of your veins and your arteries, you see. So, and if you look at give you an example, if you look at the central heating system, new tubes in the central heating system, they're all brand new, and look at the tubes 20 years down the line, and if you look at inside, what tends to happen, there's all that furring that is happening inside. So the diameter of the tube gets narrower and narrower, you see. And that's what calcification means. There's quite a lot of deposits been deposited around the arteries, you see. So it is getting narrower and narrower. And the use of the aspirin is to prevent complete blockage of that particular artery, you see. And is to prevent so the blood keeps flowing. So that's the importance of giving the aspirin in that particular setting. That's what exactly happens in a heart attack and in a stroke as well. The blood certainly stops flowing in that particular area, and then you get the damage. And aspirin is one of the drugs that we tend to use in that particular aspect. Now, in this particular example, with our colleague, with the calcification of the arteries, that's what's been happening. There's narrowing, and they want to make sure that particular narrowing doesn't get further narrowing, and is to make sure the blood keeps flowing, and that's why they give the aspirin once a day.
Yeah. Is it possible to find out whether the calcification would increase in the future, or is it something would stop by taking
Well,
aspirin?
they must have measured the calcium around it to tell you that it is calcification. Did they do a specific kind of radiological investigations to do that?
They did the X-ray. That's at the moment they've done X-ray, and they'll be doing U Doppler, I think,
The
to find out
Doppler.
to see the heartbeat on my feet, whether
Okay.
the blood flow goes. Yeah, there's
Are
blood
you
flow.
diabetic? Are you type
I'm
2?
diabetic as well.
Well, there you
Yes.
are then. So
Yeah.
this is one of the other issues with the long-term diabetic patients. They get peripheral vascular disease, and if you have got peripheral vascular disease, you should be on aspirin, or either aspirin or clopidogrel along with a statin. Those are the two important medication for your feet, so that your circulation in your feet continues not to get worse. It's to prevent it getting worse.
Fantastic. Thank you so much for your time.
No problem.
That's great. It's a general question on aspirin. So, William or Doris has asked it, which is, if you're prescribed aspirin, is it okay to use paracetamol as well for general pain? So, can you take both?
Well, the aspirin dose that you're going to be given is just going to be 75 milligrams. And that's all what you'll be given for your heart disease, to prevent heart disease complication, or for the previous caller, it'd be around that dose. You see, for painkillers, you need a very, very high dose of aspirin, about 300 milligrams or 600 milligrams. You won't be able to tolerate that kind of dosage, so it's best to use paracetamol. Yeah. So paracetamol along with the 75 milligrams of aspirin should be okay.
Great. A question here, asking about a lady's been asked to stop taking metformin, but has been asked to go on gabapentin. So stop metformin, but they've been prescribed gabapentin as a alternative. I don't know what the differences are. Do you know why that might have happened?
I don't know what reasons are for stopping metformin. She's probably type 2 diabetic patient again. I suspect. And the reason why they are giving the gabapentin because of the neuropathic pain that may be happening in her.
Yeah.
And if they're starting, I don't know how old the patient is, but there's
yeah. So does Kusumwara want to come on the phone here? So I think she's pre-diabetic. So I'm not sure why they asked us to stop. I mean, she's asked, and the gabapentin is for pain relief.
pain
Sorry,
relief, yes, yeah.
it's not for Kusum, it's for Ramnik actually.
Oh, it's for Romnik. Oh, Romnik.
Yeah,
So
yeah.
tell us what's happening.
Yeah, the metformin was asked to stop by the I don't know why. And he says they will come back to me after 3 months. The reason is not known why they have stopped this.
And has there been any other change in your medication as well at the same time?
No. Then I'm not sure why the gabapentin was prescribed to me, for what reason.
Yeah.
Well, again,
isn't
you
this
need
a
to.
perfect example? Isn't this a perfect example where you need to ask the doctor why they're doing these things, right?
Yeah, I know. But I just want to know what's the, and the gabapentin doses are three a day, 3 times a day.
Yeah, what strength is it? 100 milligrams or 300 milligrams?
It's 100 milligrams.
Yeah. So have you started it or not?
I have.
Okay. So you have to start slowly and build it up. How old are you, if I may ask?
I'm 81.
Okay, so build it, do it slowly. Probably 100 milligrams at night for a few days, and then 100 milligrams morning and evening for a few days,
Yeah.
and then 100 milligrams 3 times a day. See how you tolerate. Because if you start taking 100 milligrams 3 times a day on the first day,
Yeah.
with your age, you will become doolally, you see. So you have you'll get confused, and then you'll say, okay, I don't want to take this drug at all, you see.
Mhm.
So, but to do it slowly and gently and build the dose up, you see, sufficient enough to take your pain away.
Okay. I'm currently just
And
taking
can I just add, if the 300 milligrams per day does not help you,
Yeah.
you can increase the dose slowly and gently, but go and see your doctor as well.
But what is the exact reason why is this been given?
Well, the thing is with diabetic patients, they get quite a lot of neuropathic pain, you see. The nerves don't work very well, and they get quite severe pain. And then the gabapentin is to numb that pain.
I see. Okay. Understand now. And the other thing I just wanted to ask you, you've been taking medications for many years. Should this be reviewed by the GP after a few years?
Well, yeah, the general comment that I would make is that in life, and especially with the NHS, we tend to add medication upon medication, you see. And we need to ask the question, do I need to continue this? Be brave enough to ask, do I need it? I'm of this particular age. Do I need it now? Can I stop it? Or if we should be asking those kind of questions all the time now, you see.
Right. Understand.
Because we are just taking too many medication, you see. There could be a good reason, don't doubt me, there will be some good reason to take them, but always ask, do I need to continue with it all the time?
Thank you very much.
Hello.
Thank you.
I want to ask one question. I'm taking tablets for trigeminal neuralgia. Maybe the pharmacist, as a pharmacist, you must know about this disease, but quite a few people doesn't know about this. And I'm taking these tablets like few years. But when the medication comes, there's a different brand comes in. And I can't tolerate the different brand. Once I've started the one brand tablet, I have to continue them sort of tablets. But then sometimes the pharmacist changes and I have to request them to get me the same brand. So what is the difference between the different brand if they changes?
Yeah.
Any ingredients in a different
It,
brands?
if I give you an example, if you take a baked beans, Heinz baked beans, and if
Yeah,
you take Sainsbury's baked beans, they're all baked beans, you see.
yeah.
They're all baked beans. They do the same thing, but the amount of baked beans will be probably the same between the one brand and the other brand. You see, sometimes it is the ingredients, sometimes it's the other additives that that are added. You see, so that's the difference between brands as an illustration. So what I would suggest you do is that if one specific brand of the tablet suits you, take a name and the picture of that brand, go to your GP and tell them to write this particular brand that I want because this is the brand that suits me, you see. No other brand suits me, and this is the brand I need all the time. So the GP, if once the GP writes that on the prescription, then it is the pharmacist's responsibility to give you that particular brand, you see, and not
Yes,
any other one.
my neurologist in London, and he sent all the names of the tablets to my GP, and GP prescribes me them tablets, but when I say that I want the same brand, the GP says that we can't put in
Well,
the same brand.
they can, but I think you have to just keep on pushing and insisting on that.
Yeah, so now I set
It's
it up. Now I set it up with the pharmacy,
fine.
but still the pharmacy keep changing and says, oh, we didn't get this brand, so you have to take, and I refuse all the time. And finally, I'm getting there, but still I've got a problem with getting the same brand
So
every time.
the main thing is that if the GP writes that particular brand, then it avoids all these issues further down the line. But there's also another problem that is coming to light, is that in this country there are quite several shortages of drugs, you see, and it is happening very commonly and with common drugs as well, you see. So if they can't get if they can't get one type of the tablets, they can give you another brand of the tablet, you see. So that is happening more and more, and unfortunately that will continue. So, but in the meantime, I think what you need to do is to convince your GP to write that particular brand, and subsequently everything else should fall into place.
Yeah. Couple of months I don't get the same brand, and good job that I've got a spare one so I can keep going for a month. But otherwise I can't live without them tablets, because you know that trigeminal neuralgia is a quite rare disease that
Right.
no is.
Trigeminal neuralgia, yes, it is. If I may ask, which medication are you taking? Is it
I'm taking lamotrigine.
lamotrigine? Okay.
Yeah, and Tegolet.
Yeah, Tegretol, yes, yeah. So in those kind of conditions, I think your neurologist, he can specify these are the brands that I want to the GP, the specific brands, and he or your GP should be able to take that on board, you see.
Okay, thank you very much. I will try that again.
Thank you so much. Thank you so much, Leela, for asking the question. Bana, you've got your hand up. Can I invite you in?
Hi, Uttam Jay. It's lovely to see you again. Just a quick question. Going back to aspirin, is Rexapand as similar to aspirin?
Which one?
Rexapand.
What was the name of the drug? What was the
Rexa.
name? Pana?
Rexapand.
Flexopan.
Because my aspirin was taken off.
Roxapan.
I can't hear you. You're cutting off.
Is it
Can't hear you.
I can't hear you. Yeah, I can't hear you.
Can you try?
Yeah, you can ring me later on.
Okay. I just wanted to know if
Yeah.
because I was on aspirin and taken off that, and I was given Rexoband in place of aspirin. So I was just wondering, is it very similar to it? I'll speak to you later.
I think rivaroxaban, I think rivaroxaban. If it's rivaroxaban, it's a different group of drugs completely. Yeah.
For
And
heart
the reason why they
condition.
take one off, yeah.
Yeah.
So it's a
Yeah.
different one.
Why is it important to take medicines exactly as prescribed?
Well, the reason why they're giving you the medicines is to treat your condition in the first place. And most of the time, they will give it to you. Probably most of the people prefer taking it once a day. In terms of antibiotics, which is a short-term course, there'll be sometimes you have to take the antibiotics 3 or 4 times a day, depending on the type. If you're using the inhalers, as I mentioned earlier, if your technique of using the inhaler is not right, the inhaler is not going to do you any good.
No.
Nothing at all is not going to do you any good at all. And if you're giving yourself an injection, and if you don't put it right and don't hold it right, and if you take the needle out completely very quickly, then the injection won't, it will come out with it, you see.
Yeah.
So it is important that you do as you've been instructed to do, otherwise things won't work. And this, and not only that, it won't do you any good. Secondly, these drugs, although you don't pay for it as such, but they're a very expensive group of drugs, you see. And we spend quite a lot of millions and billions of pounds on medicines. And if people don't take them correctly, it's waste of money.
True.
Huge waste of money. It is huge. And unfortunately, that does happen. People regularly, they get the prescriptions on repeat prescriptions, and they collect the prescriptions, but they don't use it. There's a piles and piles of tablets at home. They don't use them. So what's the point of getting the repeat prescriptions? So there's a personal responsibility on people as well, that if they want to get well, they have to follow the instructions.
Have you got any myths about medicines you would like to clear today? I mean, we've talked about diabetes and all other blood pressures and that. What
Well,
are your myths?
well, the main thing is that you need to regularly check your cabinets in your house, which have got the drugs, is to make sure they are in date. And if they're not in date, you're not using them. Yeah. So to make sure they are in date. And if you've got more than one box of the tablet, then you're oversupplying it, you see. Yeah, there may be a reason to keep an oversupply, as that one specific lady mentioned about the trigeminal neuralgia and the medication, because there are some difficulties getting some medication. So that's important. The other important thing I would ask, would always ask, why am I taking this medication? Yeah. And how long am I going to take it for? You need to ask those questions as well. You see, repeatedly keep on asking.
Perfect. Thank you, Uttam. So we covered a lot of ground, and I'm conscious of the fact that we've gone way over time and impinged on Uttam's time as well here. I think lots of interesting points, but I wanted to sort of ask you one more question, which is related to something you raised before, and I think it's an important one. One of your analysis was, how do we prevent heart disease? And that if you can control that, you control some of the other issues. You mentioned there was medication that maybe came out 10 years ago. Are doctors and consultants prescribing these drugs? Are we, if this helps prevent heart conditions, are we being told about this?
Um,
What
well,
should we be asking for?
well, it is difficult. The history of the NHS is that once the drugs comes out, and if the benefits are very good, it is the authorities like the the funding, where's the funding going to come from? Where's the money going to come to pay for those kind of drugs? And then there's a NICE body, you see, and once the NICE, that's the National Institute of Clinical Excellence, they announce, they will analyze all the things, and they will say either you can use this group of drugs or you can't use this group of drugs, you see. And when they say that they can, if they do announce they can use it, there only the momentum will slightly build up within the GP community and in the hospitals, then they can start using it, you see. So it takes a long time, unfortunately, for drugs, for newer drugs to come online. My gut feeling is that probably takes about 5 to 10 years for the drugs to really get on board. It is a very slow process, unfortunately. That is, it's just, it is the nature of the game, unfortunately. It takes a long time. And I gave you the example of the type 2 diabetic drugs, which I did talk about it last time. The one group of drugs that have really changed, as I mentioned earlier, in type 2 diabetic patients, what kills them is heart disease, and we need to prevent that happening. And the newer group of drugs that have been introduced, I think, are slowly being taken up now, and more patients are getting them, you see. Advantage is that reduces those newer type of drugs, reduces these people getting heart failure, heart disease, dying early, and also it prevents them ending up on dialysis units as well, you see. So there are quite important benefits there, and we should be using more and more of it.
Fantastic. So listen, thank you very much.
Next time.
Yeah, for sure. So look, thank you very much. We've had in excess of 90 people on this call when we started, and the numbers are dwindling a little bit. So maybe people are getting hungry.
Yeah, it's time to.
What I did want to say, I took away some learnings from me, and I just wanted to repeat that for people. So one, you mentioned hydration. Make sure you're hydrated, and there, your test is make sure your tongue is moist as a way of knowing if you're hydrated enough. I liked your feedback on what time to take medication. It's personal preference, but for a couple of other medicines, which you talked about iron tablets, those should be taken on an empty stomach, and I wasn't really aware of that. And penicillin again should not be taken with food because it dilutes it. So that two things I learned. Brown inhaler, which a lot of people have, okay, it's got to be taken regularly, not just when you have a condition. So please, all of you, have a diagnostic test done, which was the advice given by Uttam. If you've got some sort of breathing problems or problems with your lungs, and if you've got the brown inhaler, take it regularly. And vitamin D, do supplement your vitamin D. I think it's important for all of us, and I will get Dr. Grimes in to talk about that later on. But Uttam, I was going to ask you, can we invite you back next week and to do a presentation on iron deficiency? Is that something that we could ask of you? Because I think so much information came out today, but we didn't cover iron deficiency in a lot of detail, and I think that's important. If you could do that for us.
Yeah, that'd be, yes.
Brilliant.
Yes.
Thank you. So I put you on the spot, didn't I? I put you on the spot. I'm sorry. But so let's do that.
I will talk to you afterwards.
Thank you. All right. Listen, on behalf of GAA London, on behalf of Bonna and myself, thank you everyone for participating. You make the health webinars, useful for us, but also the reason we put it on because of people like yourselves who join us and participate. And thank you so much. And we'll see you next week for iron deficiency.
Thank you.
Yeah. Take care, everyone.
Take care.
Thank you, Uttam.
Bye. Welcome.
Bye-bye.
Bye.
Thank you, Uttam Ji.
Thank you.
My name's Uttam Chauhan as well.
Well, yeah, I saw that on the thing. Yes, very nice meeting you.
Your brother.
Same name. All the best.
Uttam Chauhan number 2. You can take the next session if you like. Okay.
Yeah.
Yes.
If you can take it next week, I'd.
Well, I'll give you a hand if you want.
Okay. All the best.
Take care.
Bye.
Good night, everybody. Thank you again.
Good
Take
night.
care.
That was
Have
very
a
good.
lovely evening.
Thank you and good night.